Right, well, good morning, everybody. Welcome to the, I think now the second Iota conference. I think we better make a start. It's slightly later, but I think the 8 o'clock breakfast meetings were scheduled to go on till about this time anyway, so apologies for those of you who are in the room on time. Could everyone possibly check that their mobile phones are on vibrate or something? Just, I know it's a boring thing, but it's very tedious when they go off while people are speaking. I think we've got a great program. We've got a very, quite a more varied lineup of speakers than we had on the last occasions, as more translational medicine, other types of imaging. So I hope there's something for everyone who has an interest in ovarian masses and ovarian cancer in particular. As you might expect, we're starting with Professor Dirk Timmerman, who has run the project really since its inception many years ago, and he's very much the person who has glued it all together over the years. Remarkably, he hasn't got grey hair. In fact, he still has hair, so I'm not quite sure how he's managed that. I think his next job will be as European Commissioner, probably. He is Belgium, so they always get that job anyway, so that should be easy for him. I'll hand over to Dirk.
Thank you, Tom. Mr. Chairman. Dear colleagues, I'm very happy to welcome you. I welcome our medical director. I welcome all the colleagues from abroad, and we have a really good geographical spread, so we have people from all over the world. And I would like to welcome you not only to our university, but also to University town of Leuven, which I hope you can explore tonight and tomorrow. The topics on this conference will be first screening, and then the bulk of the lectures will be on pre-operative diagnosis. And then we have to make a distinction between regional centers and oncology centers. And then we also touch upon pre-operative staging, be it by ultrasound, by MRI. We will have several lectures on management and optimal treatment of ovarian tumors, both benign and malignant. And then we touch upon prognosis, which may depend on histology, type of treatment, and maybe biomarkers will be able to predict prognosis of patients. If we spoke about screening, we have to be careful that even if we discuss postmenopausal patients, you will only find about 1 cancer in 1,000 screened patients. So you have to look carefully to detect this one. And if you have a test with 100% sensitivity and 95% specificity, you will still do 50 operations to detect 1 cancer. So this means that in screening, because of the different prevalence, you need to be very careful about the test that you're using, and the topic will be completely different compared to what we are discussing with Iota. Thank you once again. So, if a test has perfect sensitivity, you detect all your cancers, and you have a specificity of 95%, so this means 5% false positives, you will still do 50 operations to detect 1 cancer. If you have an unrealistically good test with sensitivity of 100%, specificity of 99%, then you do 10 operations to detect 1 cancer. So, screening, is it helpful? And this is the big question at this moment, and we were all very disappointed by the PLCO study in the United States, because if you look at the effect of screening on cumulative deaths in the study published in JAMA, then you can see that there's no difference in mortality in the screened group and in the intervention group. And you can even see that in the intervention group, so the screened group, there's a trend of a higher mortality, more deaths in the screened group. So this was quite unexpected, and there's been a lot of criticism on this study. And now all our hopes are on the shoulders of Professor Usha Menon, who is sitting here and who will present the UK-CTOX study today. So UK-CTOX is a very big study based on 200,000 patients, 100,000 screened, 50,000 screened with biomarkers, 50,000 screened with ultrasound, and then we have a long-term follow-up and we will see whether the mortality is lower in the screened group. But we're very, very interested to see the results from Professor Menon. Iota is different. In Iota, we have benign tumors, we have virtually no normal ovaries, we have borderline tumors, we have stage 1 invasive cancers, we have stage 2 invasive cancers and higher stages, and we have metastatic cancers like Kuchenberg tumor, metastatic tumors from the stomach, from the colon, from the breast. So these are all tumors, and we want to distinguish between these different groups. So here we have a completely different scene, and that's why it's very important not to confuse screening with pre-operative diagnosis. Because you can see that the prevalence in Iota, the prevalence of cancer, is multiplied by a factor of 200 to 300 above screening studies. So if we talk about 1,000 patients, this means that we have 200 to 300 malignancies. In a screening study, there's 1 malignancy in 1,000 patients. So that's a different, and you have to adjust your algorithms if you screen or if you use your algorithm for pre-operative diagnosis. How to classify and management of ovarian tumors? Well, we want to exclude, of course, normal ovaries, functional cysts for surgery. Also, most of the benign tumors may be excluded from surgery. We can do conservative management, and this is what we touch upon in Iota 5. Borderline tumors, we prefer not to have any spilling, but certainly in invasive tumors, in stage 1 cancers, if you have spilling during the initial surgery, the prognosis of the patient will be worse. So it's very important to treat them in the best way possible. So this is by avoiding spilling, so preferably no laparoscopic surgery for stage 1 ovarian cancer, while most of the borderlines may be treated with laparoscopy. But this is a discussion for later. We're not only aiming for good, innovative research within Iota, but the main aim is to integrate the results of this into guidelines and into clinical practice. And what tools do we have? Well, the first thing is subjective assessment. I think few people in the room will struggle to call this a malignancy. This is ovarian cancer. On the other hand, some may be more difficult. Even for experienced examiners, they may struggle a little bit and they say, well, she's 84 years old. Is this cystadenofibroma? Is this a borderline tumor? I think many of you would struggle to give a certain answer. In this patient, it was serous cystadenofibroma, a benign tumor. Is this benign or malignant? Who thinks it's benign? Who thinks it's malignant? It was benign. Only Francesco Leone from Milano, he's right. Congratulations. Is this benign or malignant? Who thinks it's benign? Nobody? Malignant? Yes, it was a borderline serous cystadenoma, despite the fact that it's a very small tumor. Benign or malignant? Benign serous cystadenofibroma. So I think the most experienced examiners can classify most of the tumors, and we analyze this, and only about 8% of all tumors are really difficult to classify. This is different for less experienced examiners, because they struggle with more than half of the tumors. So what tools can we offer to make the diagnosis more reliable? Within Iota, we've done these multi-center studies in order to try to develop rules, to develop models together with the engineers that may help with examiners. And initially we were not so ambitious. We wanted to help the less experienced examiners. These days we are more ambitious and we try also to help the more experienced examiners. Have we succeeded? Well, we started a long time ago, back in 1999, together with Professor Valentin and Born and Collins, Herman Verhelst and Professor Vergoten. We have this terms and definitions paper, and Professor Valentin will present the terms and definitions later. And this is on how to describe the features of tumors. Because if we don't speak the same language, we cannot understand each other. And we can certainly not make reliable models that can be used in different parts of the world. And in different phases of Iota, we looked at the features of these tumors. We collected lots of variables, more than 50 variables, like echogenicity, anechoic, low echogenicity, hemorrhagic contents, like in here, where you see the jelly-like movement into a hemorrhagic cyst, ground glass appearance, which you see in endometriomas, and then the mixed echogenicity may be seen in dermoid cyst, where you have the Rokitansky nodes, so the white ball and the stripes, these represent hair. You have also mixed fluid levels, and this is something you can see in an endometrioma with fresh bleeding, or you can also see it in dermoid cyst, where you have fat and cystic fluid. And then you also have the mixed echogenicity, the dirty content that you see in abscesses, in PID. And Daniela Fischerova made beautiful posters on these terms and definitions. Several companies have made posters, and you can find them in the booths. So to collect them and to put them into your office to better visualize the different features of the tumors. Different phases of Iota included the first phase of model development, and this was based on over 1,000 patients, where we collected data on serum C125, on ultrasound, and then tried to make new models. Iota 2 consisted of 2,000 patients, but the external validation, this means validation in new centers, was only in 1,000 patients. Iota 3 was published last year, and this was based on 2,400 patients, and there we tried to see new tumor markers, new second stage tests like 3D power Doppler. We looked at proteomics, we looked at novel biomarkers. Iota 4, very important, because there we tested, together with Tom's group in London and in different hospitals in the UK, we tested whether the models do work in the hands of less experienced examiners, so also sonographers. And we are very happy that they kept their performance also in non-gynecologist hands. So also in different specialties, it was useful to use the models. And then at this moment, we will give the first results today of Iota 5. And Iota 5 is the long-term behavior of non-operated tumors. Because in all previous Iota phases, we operated the patients because we wanted to know for sure what was the histology. And if the patient was for conservative management, she was simply not included in the studies. Now we try to include all tumors to make sure that we don't miss cancers in the non-operated group and whether we can reduce the number of unnecessary surgery. Here's an overview of the participating centers, and this is a slide from Jeroen Kaiser, who last night defended his PhD thesis on this topic. And you can see that there's really a good geographical spread of Iota centers throughout the world. Australia is taking part as well, but it's not indicated yet. If you then look into more detail, Iota phase 1, there were 9 centers. Patients were operated within 4 months of making a diagnosis with ultrasound. And first we looked at morphology, because morphology is still very important, and you have 5 groups, and I will not go into details because Professor Valentin will do this, but you have unilocular cyst, unilocular solid, multilocular, multilocular solid, and solid. And you can see how the prevalence or the rate of malignancy goes from less than 1% to 60% in solid tumors. This was published in 2005, together with the first 2 logistic regression models. And there were 9 factors that increased the risk of malignancy. That's age of the patient, a personal history of ovarian cancer, but later on we did not take this into account anymore because the models could do based on the features and the prior history was not so important anymore. The maximal diameter of the lesion, maximal diameter of the solid component, presence of ascites is very strong. Presence of blood flow within a population, and this is a little bit more difficult, more challenging to test this. Irregular internal cyst walls, a purely solid tumor, and a higher color score. There's also 3 factors that reduced the risk in the multivariate analysis. And this is the presence of acoustic shadows, which you mainly see in dermoid cysts, but you can see them also in some malignancies. So it's not on its own a very reliable factor. But with all these features, it's important to combine them. Because if you take one feature in isolation, it will not give you a final diagnosis. But if you combine them, you can get to a more reliable diagnosis. Hormonal therapy, presence of pain during the examination. And then we made Logistic Regression Model 1. And this was based on 12 variables, and the reviewers of JCO said, can you not make a simpler model? Because 12 variables, that's a lot of work to analyze this. And yes, the group of ESAT, our engineers, worked to a more simplified model, and this was based on 6 variables only. And this was LR2. And LR2 is performing almost the same as LR1, the more complex model, and that's why in all the validation studies throughout the world, you will see that they always test LR2 and never or almost never LR1. So blood flow in the population, maximal size for the solid component, irregular internal cyst walls, presence of ascites, and then acoustic shadows. You put it in this formula, and if the risk is 10% or higher, you classify it as malignant. At that time, computers and certainly apps were not very common in the office, so people wanted to have something more useful. A table that you can cut out of your paper, stick it on your ultrasound machine, and then you have a tick box. So you can simply say, this patient has at least 4 populations, very strong blood flow, so we call it malignant. And these are the simple rules. And of course, if you develop something, you have to validate it. And there's different ways to validate it. You can validate it in your own center, and that's a temporal validation. That means that in the same center where you develop the models, you then see whether they work in completely new patients. But temporal validation is good, but it's not showing that the model is generalizable. Generalizable means that in other centers they can use it as well, and therefore you need external validation. And so these are the old centers, and these are the new centers where we did external validation in 997 patients in completely different centers where the models were developed in. And the 10 rules that, or the 10 features and the simple rules were validated in this large group. And the sensitivity for cancer was 92%, specificity was 96%. Also other models, like logistic regression models, were validated. And I will not go into this because Dr. Caroline van Holsbeke will present this later on today. We are grateful for the free study screen that we got from Astaia for filling in all the data. And so you can see whether this is ground glass appearance, what's a color score. So most of you are familiar with this study screen. And then, in the end, you see the risk of malignancy. So in this patient, it's, for example, 63%. We are also happy that the Royal College in the United Kingdom took into their Green Top guidelines the simple rules for pre-menopausal patients to classify ovarian tumors. And 2 years ago, a bright student in information technology, the son of Professor Van Huffel, made an app. And this app is freely available, and I sent an email to all of you prior to the conference that you could download the apps. And there you have Logistic Regression Model 1, 2, and the simple rules. And there's also explanation to be given. Iota 3, proteomics, new tumor markers, 3D power Doppler, other mathematical models. We'll come back to this later. Ahmad Sayasne had this great study in the UK on 300 patients scanned by less experienced examiners. And this is also a slide from Jeroen with an overview of the current status of Iota. And this clearly shows that in first Iota phases, we always had more experienced ultrasound examiners, and this was a criticism when we published the papers. Oh yes, they work in the hands of experts, but do they work in real life? And yes, they do work in real life, because also in non-expert hands, the performance was almost the same. And now in Iota 5, we have over 8,000 new patients collected, where we have a mix of patients, a mix of ultrasound examiners, and where we also have follow-up of patients. So more than half of the patients in Iota 5 are in follow-up. We have 4,500 patients that were planned for conservative management. So now we have the natural history of benign-looking tumors and see whether they really transform into malignancy, whether they show torsion, whether they do have cyst rupture, and so whether it's really indicated to operate on all of them. And that's for later today that we will present the first results of Iota 5. I thank the steering committee for helping designing all these studies. And Iota 5 will be presented, as I said, in a few minutes. Then evidence-based medicine needs systematic reviews and meta-analysis. And there's been several. There's one from Peggy Jomini, there's one from Jeroen Keizer and Ahmad Sayesne, and now there's a new one from the Netherlands, from Evelien Meijs, and that's to be published soon. But we were happy to see that Iota models were very good in this, and that actually these are the best models that we have at this moment. So even according to evidence-based medicine, we have to use Iota models. New research is on multi-class models, and this is published in BMJ last year. And if you go online to the website, you can calculate it. And for example, if you have a patient aged 55, in an oncology center, maximal diameter of the lesion is 68 millimeters, C125 is 325, then her risk of having a metastatic tumor is 38%, while the prior risk in all Iota patients is only 4%. Most Iota patients are benign, have benign tumors. This patient only has 9% chance of a benign tumor. And if we would only change a few variables, so for maximal diameter is 45, C125 is 32, then her risk profile would have been completely different. Now she has a chance of a benign tumor of 97%, and there's virtually no chance of an invasive tumor. And if it were not benign, it would be a borderline tumor. There's also other models, innovative models, like this model created by Vanja van Belle, which looks very attractive and very easy. However, the mathematics behind it are quite complex, but we will not go into this. And then there's clinical data miner. And Arnaud and Saleh developed a completely new system to collect data from clinical studies, and that can be used for any type of clinical studies. And the nice thing is that you can do inter-rater agreement studies, that you can do data analysis in the system, so you don't have to export it from one system to another system. You can have online recruitment of patients, so you can much better monitor it, and you can change things if you see that there's bugs in the system, or if you see that there's problems with the quality of your data. You can change things while you're going. On the other hand, if you have a study screen that you send to 50 centers and they have to update this, you will create a lot of problems because they have to change their study screen. Within this system, you can do machine learning, and then you can see whether you reach a plateau and when it's not of any use to recruit more patients to increase the performance of your model. And then you freeze it, and then you have a diagnostic tool. And this is already used in the Iota study with Thierry van den Bos, who is using this system for several years now. And we have several thousand patients recruited. And on our next conference, we will go more into Iota. But this is about endometrial pathology. But in the next phase of Iota, we will use this clinical data miner. And you can see that it's very user-friendly to fill in the variables. You have the simple rules. You have the results from Artnex, and then you can include the histology and the outcome of the patient. Then a very exciting new phase is also MRI. And Isabelle Thomasin-Agara will speak later today, and she developed a new scoring system, the NXMR scoring system, for difficult ovarian tumors. And so this is something we will test in the future, and I'm really looking forward to her presentation to see how MR could help in some selected difficult tumors. But this is ongoing research. And MR is not only for difficult tumors, like this is the ADNEX scoring system, but you can also use it for preoperative staging, of course. And then people tend to use now full body MRI, but more classically, CT scan is used for preoperative staging. And we will come back to this as well. Then I'm happy that translational Iota has now started, and there we will analyze new tumor markers, and we have a lot of potential new markers next to C125 and HE4. We will test proteomics and different types of omics. We will test the NIP test, which you are all familiar with, but now we will use free circulating DNA of tumors to try to detect and to characterize tumors in blood samples. And then also circulating tumor cells, and we also have different research lines setting up to look after this. But we will hear about this much more in the talk by Ann Kosemans and Sarah Blagden from UK. And then I'm very pleased that the engineers from the University of Buckingham are also in the room. And last time, Sean Gazende presented the pattern recognition studies. So the computers that recognize you when you enter a station in London, or if you're on Heathrow Airport, you're filmed, and Secret Service know that you're there. On Facebook these days, every or most pictures may be tagged by computers. So why don't we use computers to characterize ovarian tumors? And so this is the research that we're doing with the University of Buckingham. So they try to look at patterns and that computers try to distinguish them. At this moment, human beings and our models are still doing better, but it might be changing in the future. And in your book, in the Congress book, you will see that there's a nice paper from Sean Kazender on the results of this research. Then there's also the rocket study, and Dr. Sudha Sundar is here as well. And then we will try to combine data from UKC tox and Iota models to develop new algorithms for primary care, where the prevalence, as I said, is much lower. So if a patient comes to the GP with symptoms, pain or bloating, then what is the best test to do to exclude the presence of cancer? We had international consensus conferences in the United States with American radiologists and gynecologists, Canadian radiologists, gynecologists, and then we tried to come to a more universal classification. And this is one option that the system developed by Juan Luis Alcazar, who's here as well, the GIRAD system, may be twisted a little bit towards an OVRAD system, and then you can use models to say, well, this is OVRADS1, certainly benign tumor, or OVRADS5, certainly malignant tumor. And then national guidelines can say, for this type of tumor, we do this type of treatment. And that depends on availability of gynae-oncologists and others. When you registered, you've seen facts, views, and visions. So the whole issue this time is devoted to the Iota Congress, and I thank Willem Omblet for this, the editor-in-chief. You can go to the website, there's the Iota group on website. There you will see our certified members, so all the people that passed the MCQ test, and tomorrow we will have another MCQ test, so I hope that everybody will pass, and then your name will be on the website. If you don't pass, your name will not be there, but then you will have access to much more content, online lectures, and lots of educational material that we will put on the website after this conference. The last time that we did the MCQ test resulted in the Hall of Fame, and you see here the ones that got 20 out of 20, the best pathologist, the best person from the USA, and the best junior trainee. So I hope that in 2 years' time I can show your image here in this Hall of Fame. The next online model, so you can do the calculations on the website, so you can simply log into there and see all the results. There's even Facebook, and Tom forced me to go on Facebook. Our hospital doesn't want us to go on Facebook during working hours, so I have to do it in the evenings, but Iota is on Facebook, and it's very lively, so every new paper, everything is on Facebook. And there's also the International Society of Ultrasound in Obs and Gynae, and both Daniela and Antonia and me are board members of ISOOG. ISOOG has 10,000 members, and the next conference in Montreal, there will be a whole session, like in previous years, on Iota and the results of Iota. And if you want to become member of ISOOG, you can go to the booth of ISOOG here outside, and then the more of you that subscribe to this membership will get more and more discount. I would like to thank finally the speakers, Carlien van Holsbeek, Tom van Gorop, Frederica Mans, Ahmad Sayesne, Stefano Guerriero, Luca Savelli, Daniela Fischerova, Elisabeth Epstein, Antonia Testa, Jeroen Keizer, Tom Born, Lil Valentin, Francesco Leone, Dorella Franchi, Christina Fotopoulou, Vincent van der Caveille, and Professor Hani Gabra. And the Iota organizing team, Linda, Marleen, and Diane, and the scientific team in Iota that are based in Leuven and that help with all the studies, doing statistical analysis, helping in all sorts of ways. And we have very nice meetings every Monday. And the conclusion for my part is that currently we have 14,500 patients with ovarian tumors in consecutive phases of Iota studies. And the conclusion to me is that these models are very useful these days in helping characterizing tumors. Thank you. No discussion.
Well, thank you very much, Dirk. Kind of looking back, it's amazing how many things have been done. I was a bit worried I was going to turn the whole projector off there. No, it's quite amazing actually how much has been done over the years and how it's now beginning to move into other areas.